next session is a very, very prestigious and important session, as I mentioned to you. I'll request Anand Khanna and Dr. Pancholia to stay on here. And I'll request Dr. Parashar, Satish Gupta and Bindu to please join me on the dais. And Sonia to please come on the dais. This is a very prestigious session. And I don't think I need to specially introduce Mukesh here. Mukesh is a very eminent. Satish Gupta is here. This is a very prestigious session, as I mentioned to you. Mukesh needs no introduction to the audience. I think everybody, every delegate, every faculty member knows him by now. He's a very versatile personality, and he gave a beautiful talk in the previous sessions. And he is the only doctor, he is the only cardiac surgeon from Harvard who had an education on, who is an MBA, and he is the so-called economic advisor to the Harvard group of schools, a cardiac surgeon. His whole perception is changed. And you'll be very happy to know, ladies and gentlemen, Dr. Mukesh Hariawala is going to receive a very prestigious award from the Governor of Maharashtra on 21st of September, India's Most Admired Surgeons Award. I think let's give a big hand to Mukesh Hariawala before he gives this keynote address. And the subject, as you just heard recently, is going to cover is angiogenesis, stem cells and bypass surgery, a novel clinical triple therapy for ischemic heart disease. Before I request Mukesh Hariawala, may I request Bindu and Dr. Parashar to give a comment on the subject. Dr. Parashar, Bindu.
Hi everyone. I think what Mukesh is going to speak to all of us, he is going to enlighten the pathophysiology of coronary artery disease, end-stage cardiomyopathy and failed coronary intervention. As Dr. Gupta this morning alluded it to all of us that with spirituality and the modern therapy, we can wake up the what we call the dormant cells, and angiogenesis, as we all know, angio means artery and genesis is generation. Mukesh is going to talk about all three aspects of angiogenesis, which we call vasculogenesis, arteriogenesis and angiogenesis. His knowledge in this field is unbelievable. He was the first person to publish the data in 1995 through Harvard on neoangiogenesis. And he is going to give us a lot of information, benefit of stem cells and angiogenesis for clinical application in next 5 years. I think hold your breath and you're going to get so much information with live presentation and some of the technique he has utilized it. Thank you.
Thank you, Dr. Kansupada. Thank you, Dr. Chopra, for this kind invitation to come and share some of our learnings and knowledge. I must admit the fact that this has been a great conference for me from a learning perspective. The program has been of the highest order, and I am going to now make a small contribution to the program with this keynote lecture. What I am going to talk about, and these are some of my professional disclosures. I am a board director and a consultant to several American healthcare corporations, but I can assure my peers in the audience that none of them have played a role in the content of my lecture. So just to give you a little overview of what my lecture is going to be about. There's a lot of confusion in the basics and the fundamentals of cellular technologies. I think I owe it to you to share some of the fundamental clearance on cellular therapies, because this action is happening at the matrix level, and most of the therapists all over the world are acting at the epicardial level. So I take upon that responsibility of sharing that knowledge. When I was invited to Boston to begin work on this new technology, my boss, the late Dr. Jeffrey Isner, when I started wearing scrubs and wanted to start operation, he asked me to change and he asked me to put my tie on again. He held my hand and took me to the library. I says, where are we going? We should be going to the cath lab or the operating room or to the laboratory. He says, no, surgeons have no idea of molecular biology. He wanted me to study molecular biology. I spent 6 months of my entire fellowship in Boston studying molecular biology. Only when I was ready did he allow me to operate. But I think you will see from the work, it was the vision of Dr. Jeffrey Isner. As I move along, a heart failure model has never been created in the world before 1995. A true heart failure model which simulates human coronary artery disease. Human coronary artery disease is a story of acute on chronic occlusion. I had to develop a model which will simulate a human being. Here you are going to see a story not only of success, but I am also going to share you story of my failure. An integral part of success in research is failure, and I am going to share that with you. And of course, this is angiogenesis has traveled the journey from basic science research. I have been involved right from the day one. Now fortunately it has become a clinical reality, and I will show you a clinical case of marriage of so many cellular therapies, and most important, what I have learned after coming to this conference, the participation of spirituality at the cellular level. You all are cardiologists, whether you are clinical, whether you are invasive or interventional. This is what you are typically doing. Doing an angiogram, identifying plaque, whether it is a critical lesion or non-critical, doing an angiogram, giving therapeutic options to the patient, either by doing an angioplasty stent or putting a bare metal or a drug-eluting stent. I as a surgeon have been doing bypass surgery for the last 20 years. The last thing, that is what a cardiac surgeon does. But all of us, throughout all our careers, all we have been doing is offering palliation to the patient. We do not correct the disease. Often I get patients asking the question, heart disease, has it been cured? I affirmatively answer in the negative. I always say, I have not corrected your heart disease. I have simply provided you an asymptomatic palliation. All of us still today are providing asymptomatic palliation. Do not ever tell the patient you have corrected coronary artery disease. You have not. Let me take you on, jump you onto big technology over here. This is the mechanical artificial heart. This is the next level of treatment that we are offering in the Western world. This is an artificial heart, some of you who have not seen. This is a simple operation. Explantation of the ventricle, explantation of all the 4 valves. Here we put in the cones, we close the patient with this mechanical device, and this is what the operation looks. This is the operation of a mechanical artificial heart. That is a patient of ours, David, post-implantation. I'm going to show you a video, and you will be surprised that following a mechanical artificial heart, look at the exercise performance of this patient. This is a patient in class 4, and look at this girl. She was 26-year-old cardiomyopathy patient. She has no heart in her chest. All she has is the mechanical artificial heart that I just showed you. She goes to the gym in the hospital. Now she is walking around with our coordinator in the hospital, but look at her exercise improving within 6 weeks of implantation. See, she is ready to box with our coordinator. She has no heart in her chest. Some of you might have never thought this was going to be a clinical possibility. But here is a patient. 10,000 hearts have been implanted all over the world. Very soon, this technology will be available in India. I am the brand ambassador for the total artificial heart, and I will be bringing this to selective centers soon in India. So what exactly are the different kind of heart failure classes that you see? These are all the different myopathies. I don't need to educate cardiologists on myopathies. I also, 15 years ago, I used to be involved in transplantation. Transplantation again is not a difficult operation. Any cardiac surgeon trying to tell you that transplant is the most difficult, melodramatic operation in the world is simply trying to impress you. Believe me, pediatric cardiac surgery is the most difficult, and neonatal cardiac surgery is the most difficult thing that a cardiac surgeon does. I am none of that. In fact, I do easy surgery. I do artificial hearts. I do transplantation. What exactly is transplantation? Transplantation is finding a donor. Only donor offered is the patients who unfortunately befall through vehicular accidents. So it is explantation of a healthy heart, transport of a healthy heart, implantation of a healthy heart with all the major pipes reconnected. There are several issues of transplantation, immunosuppression just being one of them, cancers being one of them. But the bigger problem is that there are hearts that are less available as about the total need of the patient. That is when I began taking interest in cellular therapies. I says, but my heart still beats for India. I'm always thinking, during this lifetime, what can I do that I can help my motherland India? My heart beats for rural India, not for expensive operations. I am the brand ambassador of the most expensive operation in the world, which is mechanical artificial heart, costing $100,000 US. But still, I am not convinced I'll be able to offer a service to my people. That was my motivation to take interest in angiogenesis. Very often, I'm also called father of angiogenesis. Let me make a correction, I am not. The true father of angiogenesis is Dr. Judith Folkman. Dr. Folkman is a pediatric onco surgeon. He's a pediatric cancer surgeon working in Children's Hospital in Boston. I used to often go to sit and listen to his lectures. I had no idea what was cellular therapies. So after I heard Dr. Judith Folkman talking about angiogenesis, all he was talking about is this slide over here. What is angiogenesis? What are cancer surgeons all over the world trying to do? They are trying to shut off blood supply so that the tumor will shrink and eliminate the cancer, supplemented by radiation therapy, chemotherapy and all adjunct therapies. I used to listen to Dr. Folkman. I've always believed in science, no question is a stupid question. I had the guts at a very major international conference where Dr. Folkman was talking as a keynote, which I'm giving now. He was using the word angiogenesis very prolifically. I raised my hand just like one of you. I asked Dr. Folkman, and he's from Harvard, he's from Boston. I says, Dr. Folkman, I've been following your pathway. You keep using the word angiogenesis. May I ask a question? And please tell me it's a stupid question. I will take pride in it. I asked Dr. Folkman this question in Chicago, not in Boston. I asked Dr. Folkman, you are actually doing anti-angiogenesis. You are not doing angiogenesis. My interpretation of the English word angiogenesis is growth of blood vessels. You are shutting off blood vessels. You are, Dr. Folkman, doing anti-angiogenesis. He really liked my innocence. He says, he called me, he says, come to Boston again, come to my office. You will not believe it. He offered me $4 million. Not as a salary raise. He liked the concept. He didn't even ask me for a protocol. The reason I'm giving you this story is inspiration to researchers. He gave me $4 million. Do what you want. You do angiogenesis. I will continue my work on anti-angiogenesis. Such a fantastic opportunity to get at the age of 31. I was just 31. One of the principles of angiogenesis, remember, and any kind of cellular therapies is that when you offer a cellular therapy, internally there has to be a receptor. Then only the handshake will occur. Many people keep injecting like crazy people. I tell them, but where is the receptor? They have no idea what a receptor. That is where the vision of Dr. Isner comes in, who taught me, read 6 months molecular biology. And you will see his wisdom. A cardiac surgeon has no idea about molecular biology. I am one of those surgeons, I think now I have a reasonable idea of molecular biology. So I began my experiments. When you look at the scientific literature, every cardiac experiment is done using a dog. This slide is not a story of my success. This slide is a story of my failure. One of the few failures I've had in my academic career. What I did is, I got these massive dogs. I opened up them and I started ligating their coronary arteries. I thought I'm simulating human disease, circumflex, right coronary, LAD, everything. I would put them after ligation on the treadmill. Believe me, you are seeing this treadmill. I am sitting on the floor over here in the laboratory taking this picture. This dog, after total coronary occlusion, is still running at full speed on the treadmill. I says, why is this dog not becoming ischemic? Why is this dog not infarcting? I have just ligated all his coronaries. The answer is on autopsy and angiogram. Look at this picture over here. This is a picture of the coronary angiogram of a dog. How can this dog ever have an infarct? Look at the collateral communication of left system and right system. Completely reperfusing. If I shut left system, right system is supplying and retrogradely filling the left system. This dog will never infarct. Here is, I have already spent $1 million of the $4 million. The CEO of the hospital, Dr. Collins, called me in his office and he said, Doctor, you're doing very good surgery, because as a surgeon I'm not failing. He says, but we are going to fire you. You are going to lose your job. Your salary is $36,000. You have already put $1 million in the gutter, in Indian terms. I said, that's all right, sir. No problem. I did not fail as a surgeon. Fortunately, the chairman, Dr. Symes, Dr. Isner, Eugene Braunwald, they all said no. You can't fire him. What did he do wrong? He's a good surgeon. 10 out of 10 surgically correct experiments. Protocol is failing. Protocol is failing. I am trying to think, what can I do? I am not interested in retaining my job. I am a 3-continent qualified cardiac surgeon. I am not into job security. I am into science. I had a golden chance with so much money to do. What I did, I had a technician called Jeff Horowitz. He was a technician. He was the farmer's son who was supplying me animals. He told me, Doctor, I am not a doctor. You are the doctor. Come to the farm. I said, for what? He says, I have heard veterinary doctors who operate on animals, they talk differently about the dog. I think pig will be a good experiment for you. Look at this pig. He took me to the farm. Now imagine a volunteer, a farmer's son in America is teaching cardiac surgery to a cardiac surgeon. But I have no ego. When it comes to science, keep your ego aside. You will never prosper if you carry the baggage of ego. One of the very important things I learnt in life. Now look at this angiogram. Look at this angiogram over here. Can you tell me which is the pig's angiogram and which is what Dr. Parashar and all do every day for a living? I bet you don't. Which is the pig's angiogram and which one of it is a human angiogram? Look at the left system. Perfect anterior system, perfect circumflex system, perfect right coronary. Most important, no communication between left system and right system. This is human coronary artery, normal coronary artery. Now I found something. Now I said, I will start experiments. My boss said, go ahead. You have $3 million left. Burn the $3 million. Go back to India. You are an honorary in India in the top hospitals and you start your business of coronary bypass surgery. I says, no. I think I found the model. Here is the animal protocol. You may wonder, why am I incubating so much in an animal experiment? Remember one thing, bench to bed is a very difficult journey. I'm going to show you that whole journey and the science behind it. Okay? I'm going to operate on this animal on day 1. I'm going to create an acute on chronic ischemic heart failure model by day 30, which is simulation of human coronary artery disease. Human coronary arteries don't get 100% occluded. It is always acute on chronic that leads to heart failure. Remember this physiology. I am reproducing that physiology. On day 60, I am going to now sacrifice this animal. I am going to explant the heart and I want to see whether I have succeeded in 100% reversal. What am I going to use to do this? This is amyloid constrictor. Amyloid constrictor is a metallic ring, but it has a small opening over here. The inner lining of the metallic ring has casein. Casein is a milk protein. When it comes in contact with pericardial fluid, it will swell. When it will swell, the lumen of this amyloid constrictor is going to become smaller and smaller and smaller. That is what is going to become acute on chronic ischemia. I don't want to go into a phase of infarction because now I want to reverse the ischemia. I am choosing the circumflex territory over here. Circumflex provides 22% of circulation to the left system. If I put this constrictor on the LAD, I will create a very large ischemic zone which I may not succeed in reversing. That's why I am choosing the circumflex territory. These are just the operative steps. I'm not trying to make you a surgeon, but look at it. A left lateral thoracotomy, simple. Opening up of the heart over here. I've identified the circumflex territory and the vein. I'm placing this amyloid constrictor. This is where even my boss was failing. He said, let me put the first one. So many American surgeons were trying. But American surgeon, cardiac surgery in 1995, there was no beating heart. They were not used to manipulating coronaries on a very fast beating heart. Pigs beat at about 120. I was trained in England. I was operating on hearts beating at 180 because we operated on fibrillating hearts. My boss, Dr. John Wright and Professor Magdi Yaqub, who is now knighted by the Queen of England, we were operating at, I was trained on a faster beating heart than the pig's heart. For me, this was slow heart. This was slow heart. So my boss took his gloves off and said, Mukesh, you finish the operation. I created 10 models, 10 out of 10. To me, I am operating on a slow heart. I am trained at 180, this is 120. Fortunately, I succeeded 10 out of 10. Model created, animal sent back to the farm. Look at, I am bringing the animal back to my laboratory. I have a whole cath lab to myself. Look at this, total occlusion over here. Look at my constrictor, it has not slipped. This is the circumflex territory. It is perfectly fixed over there. No distal runoff. Look at this. Over here, left circumflex occlusion. The constrictor, very simple, just two groups. One is the placebo group, where I am going to inject saline. So it's going to have, but the second thing that I am going to inject is VEGF. Vasculoendothelial growth factor is an endothelial cell-specific growth factor. It is the only one. There are many growth factors, FGF, PDGF, and so many other, entire family of growth factors. I am choosing the most powerful one, VEGF. I will inject VEGF in 10 of them, and I will give placebo, and it will be blinded. I do not know which patient, which pig is getting VEGF or this. See, day 60, I bring back the pig to my lab. Immediately, I kill the animal and I explant the heart. I'm now also becoming a histopathologist. I sat with the pathologist and I said, I will do the pathology. You just make sure I'm doing it correctly. I want to learn pathology also. Look at my slide. You see this? This is what human disease is, the control disease, a completely deformed matrix. This is where all you cardiologists listen to the patient who is saying, I'm getting chest pain. Where is the chest pain coming? It is coming from a neuronal activation, but this is deformation of the matrix. Oxygenation is not happening at the cellular level between two cells. Patient is complaining of this, but look at my treated animal, 100% reformed matrix. This animal is now, but look at this angiogram. I have multiple evidence. Look at this angiogram. Control, look at this infarction. No distal runoff. Now look at my treated animal. 10 out of 10 is showing this. Look at these microvessels that I am able to pick up by angiogram. It is very hard to pick up microcollateral vessels on an angiogram, remember. And all you cardiologists, I hardly need to emphasize. Look at this distal runoff. Only treating with vasculoendothelial. This is what is a bypass to bypass surgery. When I was presenting this at the American Heart Association, Dr. Denton Cooley, father of modern cardiac surgery, he stopped my presentation. He was sitting where Dr. Chopra is sitting. He says, stop, Mukesh. He calls me Mukesh by first name. He says, stop. He said, Mukesh, he was 80 that time. He says, Mukesh, I never knew I would be living to see such an angiogram. A growth of new blood vessels. But he asked probably the best question a moderator has ever asked me. The best question. He asked a simple question. He says, Mukesh, are these new blood vessels? What is your answer? My answer was this. I shifted from the angiogram my laser pointer and I said, Dr. Cooley, great question. Answer is right here in histopathology. If this is new vessels, I must see an angioblast over here. When we begin life in fetal, at the fetal level, the first cell identified that will create blood vessels is an angioblast. I told Dr. Cooley, no angioblast. This is not new blood vessels. This is nature's vessel that is lying dormant in a hibernating myocardium. All I have done is given VEGF, I have pulled the trigger. By giving VEGF, I have pulled the trigger, these small vessels have sprung up. It is like finding oil in a desert in Dubai. They make the hole at the right place and there's a fountain of oil. This is fountain of blood vessels going over here. Look at this, NOGA scanning and all showing complete reperfusion by NOGA scanning. I am using every possible documentation technique to substantiate my protocol. Look at this, this is the first article referenced over here ever written on angiogenesis, ever. This picture has gone into 50 surgical textbooks of the world. This is what one big milestone in angiogenesis. In 30 days, I am the cardiac surgeon, but I have great respect for cardiologists. This is not me. This is Dr. Jeffrey Isner. Look at this. Jeffrey Isner is standing in front of an open chest like a cardiac surgeon. I told Dr. Isner, you do the first injection of growth factor. This is clinical trial. 30 days fast track FDA approved clinical trial. Because this was going to change the dynamics of ischemic heart disease and even understanding heart disease all over the world. Within 30 days, Dr. Isner is standing over here. Beautiful, look at Dr. Isner injecting growth factor over here. VEGF injected by Dr. Jeffrey Isner. Cardiologist never stands in front of an open chest. We don't allow cardiologists to stand. I told Dr. Isner, you go ahead. But look at this perfusion over here. It's all filling up within 30 days. Look at the big publications that came out. Journal of Surgical Research, where prime research is published. Most Nobel laureates published in this journal. Not in NEJM, not in circulation. It is Journal of Surgical Research. But look at my boss's such a great heart. Look at this. Who is the first author on the world's first? Mukesh Hariawala. Look at Jeff Isner. Here, way down, Dr. Symes, chairman of cardiac surgery, last position. They gave me the first position. The first ever review article ever to be written on angiogenesis was given to Harvard. Look at me writing from Harvard. Mukesh Hariawala, Frank Selke, my new chairman. Chairman is taking second position. This article was supposed to be written by Eugene Braunwald. Eugene Braunwald says, Mukesh, I am not qualified to write. You go. I was still a fellow. In America, fellows don't write review articles. Only professors write. This is the first time Harvard gave opportunity to a fellow to write a review article. This is what helped me. After these publications, I am one of those rare Indian Americans. I was made an American citizen for scientific excellence. I have no relatives in America. America made me a citizen and retained me over there. These are several new angiogenesis non-invasive therapies that are now going to come into the forefront. Angiogenesis is going to touch every possible speciality, whether it is plastic surgery teaching hemangioma or ischemic heart disease. Look at this non-invasive therapy. Now, shockwave therapy is shooting from without opening the chest, reperfusion using angiogenesis as the application. I am a speaker all over the world even for this therapy because I can speak on angiogenesis. I do not perform. You all cardiologists will be soon using shockwave therapy because look at the perfusion shockwave is doing non-invasive. I believe this will be a new option for the no option patients who cannot have bypass surgery, who cannot have angioplasty or stent. But now you all will be able to offer that to your heart failure patients. What angiogenesis has done, it has at least proven to the world that cellular therapies work. It opened the biggest door in the history of medicine, and that is stem cells. Stem cells is the science of stem cells for human consumption has come from angiogenesis. Angiogenesis told the world cellular therapies are working. Angiogenesis is working. Stem cells. But I want to again take this platform to educate you. Don't use the word stem cell loosely. Everybody says, oh, we are giving stem cells. We are treating stem cells. Sometimes I go to so many centers in India. Believe me, cross my heart, they are not offering stem cells. I feel so bad for the patient. I feel you're not giving stem cells because their fundamentals of the operator about stem cells are not clean. I walk out of the operation theatre in anger. I said, surgeon, when you finish, come and see me in the surgeon's room. I'm already wearing my tie. I don't want to see this operation. Why? I'm going to educate you on that. There are two types of stem cells, not one. There are several types. Important thing to understand is what is an embryonic stem cell and what is an adult stem cell. Embryonic stem cell is this, left side of this slide. When pregnancy occurs, this is the blastocyst, the first form of life, but not a pulsatile life. Look at this very small number of cells, maybe 15 or 20, sitting right over here. These cells only exist from day 7 to day 12. After that they disappear because after that the body starts forming. It is no more an embryonic, but these are the most powerful embryonic stem cells in the world. You can bend these stem cells. In stem cell language it is called pluripotency. Pluripotency is a new word. It never existed in medical dictionary. It is a word designed for stem cells. Pluripotency means flexibility of a cell. Now in my laboratory, from this stem cell, if I aspirate from the woman, I can make a designer heart. I can make a kidney. I can make pancreas. Because this cell has not made up its mind what it wants to be. Now I am the Armani of stem cells because I become the designer. Look at this, I can make anything. But unfortunately, ethically, there is a very big issue. Ethically, what the issue is, I am essentially creating an abortion. I am destroying the birth of a child because when I aspirate this blastocyst ceases to become a baby. I have done an abortion. These cells are very powerful. Do we want to use the power of stem cell to help people by destroying babies? I believe not. I don't think it is some. I have met Mother Teresa, shook hands with her. I don't think she would be happy if she was alive. Now let's move from embryonic stem cell to adult stem cell. We have an opportunity in adult stem cell. If you aspirate stem cell, you can correctly treat patients. And I'm going to show you some of those. I'm now coming into clinical reality. As I mentioned, the big differences between adult stem cell and embryonic stem cell. Embryonic stem cell, because they are pluripotent and very flexible, there are chances you can get tumor. You don't want tumors in the entire human population. That's why it's not good. Because they are so flexible. They can, adult stem cell, very safe. There is no teratogenic risk. There is very little immune rejection. And certainly, there are no ethical conditions. So the future of stem cell is going to be adult stem cell and not embryonic stem cell. But adult stem cell have 10% of potency and power than an embryonic stem cell. So we have begun some work on amplification of the power of adult stem cell. We want to make the adult stem cell as powerful as the embryonic, and these will also become designer cells in the future. This is the way ideally stem cells should be taken for whatever disease state you are trying to treat. Here is the iliac crest. I am showing you over here. Some of the operations that I go in India and I watch, the problem is over here. They are aspirating from the correct place, which is the iliac crest. They are using such a small needle. A small needle does not even reach the spongy layer of the marrow. The stem cells reside in the spongy layer over here of the marrow. This needle must go right into full penetration of cortex into spongy layer. You can inject the stem cell peripherally, systemically, even intramyocardially. That's not the issue. Make sure you're injecting stem cell. People are making the thing, they are injecting cortical bone, which looks red in color, but there are zero stem cells in it. That is very important. Here is, as clinicians, I'm taking you now into direct. We are implementing clinical angiogenesis, clinical stem cells, 22 cases being done. Here is a clinical case which Dr. Parashar and Dr. Chopra must be seeing in their office very regularly. A typical case. Look at this. 62-year-old diabetic, failed right coronary intervention, fortunately a non-dominant right. So you can let go. Patient is going to survive, not complain of angina. But look at the angiogram of this patient. Diffuse circumflex and a very dominant right. A left system, LAD. This needs to be revascularized. This can be left alone. But because this patient has diffuse circumflex disease, neither can any of you angioplasters and stent placement specialists. You cannot put a stent over here because the disease is distal, it is diffused. As a bypass surgeon, I cannot put even a graft there. I cannot do a sequential from the mammary. I cannot do a radial or a free graft because the recipient vessel size is very small. It will lead to acute operative occlusion because the flow, antegrade flow coming is going to be so powerful, it will lead to stenosis at the site of suturing. Now this poor patient has nothing. I'm going to offer a third option to this patient, a combination of angiogenesis. But how am I going to stimulate angiogenesis? I'm going to use powerful laser. Anytime you use laser, you endogenously release growth factors, which is the VEGF in my original experiment. I'm going to stimulate VEGF, and now angiogenesis is going to happen, and I'm going to create a marriage of angiogenesis and stem cell. Look at this over here, and here is a video of a clinical case. I wanted to do the clinical explanation of the case before you. This is a triple therapy that you must have read in the media that I often talk about. One of the reasons I'm getting the award for India's most admired surgeon is this protocol. Look at this. The patient is over here, iliac crest is over here. I'm marking on the iliac crest. Now the aspiration of the iliac crest is going to take place over here. You can see going deep down, deep into the marrow, deep into the spongy layer. See how much drilling I have to do. I am not going just through fat and pulling out whatever I see in red color. I'm going deep down. How much effort has to be made over here? Now I'm further puncturing. I'm trying to go here. Look over here. I'm going right over here where the layer belongs. Why is it not playing? Huh. Ah la la. I'll try. Okay, not to be repetitive, but this is the start of the operation that you're going to see. Just a 1-minute clip. The operation is 90 minutes. I'm not going to show you 90 minutes of the operation. But I'm going to show you key components of the operation, which is aspiration of stem cells, filtration of stem cells, and then injection of stem cells, and I'm then going to show you reperfusion studies of what the results. This is a clinical reality of the basic science, this thing. Udhar se mat play karo. Yahan play kar raha hu. Yahan play kar raha hu. Don't do anything there. Oh dear. Oh dear. Shush, shush, shush. I think these cardiologists did it on purpose. They didn't want surgeons to show surgery. Dr. Parashar, ऐसा तो नहीं किया ना आपने? सर्जन को ज्यादा पोडियम दे दिया 40 मिनट्स का, तो बोला इनकी सर्जरी रोक दो. हाँ? Okay. Unfortunately, this video is. Okay, anyway, I'm reached somewhere, some progress is happening. This is the stem cells that have been collected. Okay, good. Now, look at it. This is the laboratory where the whole stem cells are being isolated, filtered, and everything happening over here. This is our hematologist doing that in the laboratory. And now it is going to come to the theatre. It is going to come back to the theatre where stem cell injection is going to be done. Shall I just proceed without it? I'll do the, okay. Anyway, this is the powerful Lima graft that I have put. This is the LAD, you can see internal memory. Now I'm firing the laser shots over here. You are seeing this is CO2 laser being done at the back of the heart, pulling the heart, retracting and giving at the back, which is the circumflex territory of the heart. So these are powerful lasers that are being done. Right, oh geez. Okay, anyway, let us proceed without this. What I'm going to do after this is I'm going to inject in the periphery of the laser where the laser channels have been creating. I'm injecting now the stem cells over here. If you look at the diagram, this is the laser, this is the injection. But as cardiologist, I want to open something out that you have a bright future about. What I'm doing in open heart surgery, very soon, cardiologist will be able to come through a catheter, drop the catheter through your aortic root, come into LV, uplift the catheter, and you are going to do it by catheter over here. You can see you are going to do laser also through catheter, endomyogenously, also inject the stem cells from within. Now, triple therapy may become a closed triple therapy. No need of cardiac surgeon if there is no bypass to be done. So this is a potential that we are working on. Okay, let us go on. These are the early results of 22 patients. Look at these black dots over here. These black dots are the ones where I had fired those 12 laser shots. Look at this. This is the post-perfusion scan. All become green. This is because of a combination of stem cells and angiogenesis. Look at the ejection fraction improving right over here. This is just stem cells and TMLR. Here on this slide, I'm going to be critical about myself as a surgeon. Look at this EF improvement. Of course, when you combine this with a powerful Lima graft, look at this EF flying very high in the sky. That is because now Lima is doing a job. Many surgeons, cardiologists and research scientists ask me, Mukesh, really did stem cells do the job or is it your powerful Lima graft? This is a valid criticism. All I say is that at least I'm augmenting and providing some service in a zone which had no option. Give it some time and we will prove to you that stem cell is doing the job. Look at this slide, histopathology over here. This is what you remember the basic science slide of mine, distorted matrix. This is a human distorted matrix over here, completely fractured over here. This is a stem cell. I'm injecting this stem cell. This reformation is taking place. This is post-injection, a completely restored matrix. Look at the stem. It is like the umbrella was closed. I opened up the umbrella. Look at this. No fractures of the endomyocardium over here. This heart is now completely reformed and beating over here. This is where the action took place, and now the next step we are going is, why only treat ischemia? What about the patients who already have had a heart attack? Our next protocol is cardiac myogenesis, where we want to treat even infarcted tissue. Thank you very much, and we'll be happy to take some questions.
I think, Mukesh, this was very well done. Hopefully everybody enjoyed. Now, from cardiology standpoint, I want your perspective for the future application, which you alluded to, percutaneously doing it, and also for non-invasive therapy, which you showed, especially shockwave therapy. Is there going to be any future research by the company to show in early stage of angina rather than refractory angina heart failure? Because to my knowledge, there are not enough clinical evidence yet. But based on what you're describing, if angiogenesis is more for release of anginal factors, is there any future in that?
Yeah, I think non-invasive therapies like ECP and shockwave therapy do have a future. The only limitation I believe ECP has is it is not focal, it is generalized. You feel a generalized well-being because by counterpulsation technologies, you cannot target circumflex or right coronary or LAD using ECP. ECP is good, well-established methodology to treat refractory angina. But shockwave therapy, I believe, has a better future because you can zone target where to give the shock waves and stimulate angiogenesis. So this is going to be a further clinical trial that we are working on. One arm of the clinical trial is going to be based in India, and we will see in the future the progression of this technology.
Sonia?
I would like to comment that in Cairo University we have AMSIS project, which is a combined project with the Köln University to do the studies of stem cell in cardiomyopathy. And I wonder, when you injected the stem cell in the heart with the Lima graft, what makes you sure that it was taken well, that it is the cause, what is the carrier you used, what is the vehicle you used? Are you sure it adhered to the muscle?
Yes.
There is nothing that is till now confirming that the stem cells
Yes.
injected are the cause of the...
Great question. Great question. In fact, I remember, speaking in Alexandria in Cairo at the Cardio-Alex meeting about this particular topic where you were present. The answer to your question is that, in the interest of time, I did not show you some of the analytic material. What we do is we do tagging of stem cells. We do nuclear tagging of stem cells. So if numerically we tag 100 cells, we are able to find out where all the 100 cells in the myocardium and what they are doing. Let me admit to the fact that if I inject 100 cells, I am able to tag only 94. 6 of them are getting lost, either due to myonecrosis or due to conduction fiber transgressing. When you do, arrhythmias are triggered, and that leads to cell death that is happening at that level. But eventually we want to track every 100 cell multiplied by 1,000,000 what they are doing in the myocardium. That is the only way we will be able to quantify the success of what we are doing.
Satish, be brief.
Yeah. See, this is a beautiful article, beautiful presentation. Just want to add on in our Abu Healthy Heart trial, which is going to be published, we have shown a mean increase of 10%, 10 point something increase in ejection fraction of these patients with lifestyle, with Raj Yoga meditation, diet and exercise. So we have been able to induce that, improve the ejection fraction by collaterals and ejection and angiogenesis.
Right. Yes, definitely.
And opening of blockages.
Definitely. After coming to this meeting, I am going to in future protocols make triple therapy to quadruple therapy, because I believe at the cellular level, spirituality and peace of mind and all of that state of mind is going to play an augmenting role in the regeneration of myocardium.
Especially bliss.
Yes,
Hala.
absolutely.
Hala?
We were doing this percutaneous lasers interventionally like 10 years back, the PMLR, but it never showed any convincing result. Is it the PMLR doesn't work alone, or if you give a growth factor or a stem cell, then it works?
Yeah, I think that's a very valid question, and it's a very positive, critical question. TMLR, as you know, transmyocardial laser revascularization, which we as surgeons used to do, was originally done to create channels, hoping that there will be reperfusion. I am applying the principles of TMLR, but I am not dependent on the patency of the channel. I don't care if the channel shut off within 6 weeks or 6 months. All I am doing TMLR is pulling a trigger to release cytokines, and when angiogenesis springs open, even if the channel is shut down, I have still triggered therapy. So I am not dependent on patency of channels.
Okay, Hala?
I'd like to congratulate you. I'd like to congratulate you for this honestly, heartily, and most professionally presented lecture. From the pediatric point of view, I'd like to, this open hope for the children with post-viral cardiomyopathy, children born with anomalous left coronary artery from the pulmonary arterial kappa. So we are going to inject factors that increase angiogenesis. I'd like to ask, where about exactly you're going to inject into blood vessels or into the myocardium? And how long do you think dealing with young hearts, not the post-ischemic
I think
adult hearts?
certainly there is definitely a role for treating cardiomyopathy in the pediatric age group. I believe is that direct cellular injection at the muscular level is going to be a better therapeutic option rather than coming in through a catheter, because when you come through a catheter you have to come in.
Ladies and gentlemen, I think the time is up. I would just like to give a concluding remark. This was the most outstanding presentation which Mukesh Hariawala has given. And I think he has opened new vistas. I firmly believe that angiogenesis is a huge potential, especially in our continent. There is a huge degree of diffuse coronary artery disease with very poor peripheral runoff, and the way we are finding a degree of restenosis after graft occlusion and stent occlusion with uncontrolled diabetes and dyslipidemias and hypertension and whatnot, I think angiogenesis is a huge potential. I have just two comments for you, sir. Number one, I'll request you to take a lead in opening a World Angiogenesis Association today. Number one. Number two, I firmly believe, as a practitioner for last 37 years in practice, with an underlying experience, that angiogenesis is going to be panacea in the years to come.
Thank you, sir.
We have to work very hard. It is just a beginning. When there is a beginning, there is a lot of negative criticism. We have to overcome that criticism. Because since I worked very little bit on the angiogenesis, and I feel there is a huge potential. We have to work, we have to use multidimensional approach to generate angiogenesis by giving more VGF or hepatocyte growth factor or fibroblast growth factor, or reduction of the increase of interleukins, or reduction of HSCRP, so many things. So I think it's a new vista and you need to be encouraged, and I think you're doing a wonderful job. Let's give a big hand to Dr. Mukesh Hariawala for his outstanding presentation. It was a very bold and a very dashing and a very informative presentation. May God bless you.
Thank you. Thank you, everybody.
I just have one announcement to make. You are being given feedback forms. Please fill up these forms and return us in the evening in the validity session. Validity session will be at 6 p.m. where Health Minister, another Cabinet Minister, and Dadi and Nibay Bhai will be here, and you will share your experiences. You know, what you have experienced in last few days.
Ladies and gentlemen, I think before Padmanabhan make an announcement, it's 1:47. So we'll meet here at 3 o'clock for the next session. Is it okay?
It's too late.
It's 1:48 already. So 2 o'clock is already there. We go for lunch. It's going to be 3 p.m. So I'm telling you, we will meet at 3 p.m. Have a relaxed lunch. Don't be in a hurry. We have enough time. And then we'll have 3 or 4 sessions. We'll finish up by 4 o'clock, I think. And I think I'll request Dr. Parashar and all other dignitaries to join me on the dais to put a medallion and give a very important token of appreciation on behalf of the organizing committee to Mukesh.
6 p.m.
The validity function, it will be at 6 p.m. here. I'll request all of you to be here. It's a very prestigious function, and we'll have some important awards and accolades to be given at 6 p.m. All the people who are staying here till evening, please come here in the same hall. It's going to be an important ceremony at that time. Mukesh, let me also be a part of bestowing this. Don't leave me alone here.
Ladies and gentlemen, that was Dr. Mukesh Hariawala from Harvard Medical School in Boston, Massachusetts, United States of America, delivering the lecture on angiogenesis, stem cells and bypass surgery, a novel clinical triple therapy for ischemic heart disease. And we now break for lunch. As you've been informed, we'll reassemble by about 2:50 in the afternoon. At 2:55, with the invitation to the chair, we have a guest lecture by Dr. G. N. Mahapatra. That will feature emerging concepts in cardiovascular perfusion and molecular imaging. Thank you very much, ladies and gentlemen. We'll see you at 2:45.